Hello, my name is Kristen Talbot, and I am the program coordinator for the MAVEN Project. Thank you all for joining us today, and thank you to our friends at El Rio for hosting today's session on how to assess cardiac concerns in children and adolescents in primary care clinics with Dr. Rogé. Dr. Claude Rogé completed his training at UCSF and was hired at Kaiser Northern California. He started the regional echo lab at Kaiser San Francisco and practiced pediatric cardiology at Santa Clara and San Jose, and was also a clinical assistant professor of pediatrics at Stanford University. He retired in December of 2012 and was asked to be the medical director for school health clinics of Santa Clara County, an FQHC serving the underserved population in Santa Clara County, and now he volunteers for the MAVEN Project. Dr. Rogé, when you are ready, please begin.
Okay, let me see from the beginning. So good morning, everyone, and let me go over this first slide briefly here. So I think we don't need to go over some details here. Okay, so today we are going to talk about how to address cardiac concerns in children and adolescents in the primary care setting. So this is an introduction to the field of pediatric cardiology, and we will focus on two specific areas, sports physical and the importance that primary care providers plays in that role in detecting the very rare cause of sudden death. You want to exclude that before people are allowed to play sports. And then we will go over what's different in the context of the COVID-19 pandemic. And then we will go over many of the conditions, the cardiac conditions that are actually detected first by primary care physicians or nurse practitioners. So the goal of this introduction is to introduce pediatric cardiology and to make the primary care provider better equipped to evaluate the child, and in most cases, reassure the parents that their daughter or son has no heart disease. And most of the time, the findings are either normal in children or not related to an abnormal heart. So let's first ask that question: what situations may cause a parent to worry about the possibility of heart disease for their child? And basically, in primary care practice, you are going to encounter lots of children with heart murmur. You are going to hear that, and you will have to talk about it with the child and the parents. And then, of course, parents are with children if they have symptoms, syncope, palpitation, and chest pain. And of course, when you take the family history, you will find out that there is a family history of heart disease. Of course, there are other circumstances, but we have limited time, so we'll mainly focus on these questions. So let's keep in mind that in children who have heart murmur, even syncope, palpitation, and chest pain, heart disease is actually fairly low, but we want to make sure we exclude the heart condition causing these problems. And we can start by asking what goes through a mother's mind after we tell them that a child has a heart murmur. And this is what they are thinking about. About half of them think, oh, my child is going to need to take medicine. Or, 40% think, oh, we are going to restrict him from sports. 30% think, oh, yeah, he's going to need cardiac surgery. Or 20% think that, it's going to happen to the other children. And of course, some people start blaming themselves. I probably did something wrong during pregnancy. And some people are worried about premature death. So why is there so much anxiety when we bring up that subject of just your child as a heart murmur? Well, for one thing, let's not forget, before the pandemic here, heart disease was the #1 cause of death in the United States. So, most likely, the parents of the child are aware of either a relative or a friend who died of heart disease. But in addition to that, the heart is the most important organ in the body. Now, you will expect this to be told by a cardiologist, but I'm going to show you, I'm not the first one to think that. If we go back to this continent, in the Aztec culture, for instance, and other Mesoamerican cultures, the heart not only belongs to the individual, but also belongs to the gods, and especially the sun gods. Apparently there were 5 at least. And here is one of the most prominent one, and I will try to pronounce his name. But the feeling was that the sun gods really sacrifice themselves and fight all the time against darkness. And that's the only way that man can survive. And so in return, there was an obligation for men to offer sacrifice to the sun gods. And the best offering was actually to offer a beating heart. And that was extracted from a live person through the abdomen, the diaphragm, and offered was still beating to the gods. Now, in other cultures, if you go to Africa, in ancient Egypt, after you die, on your way to afterlife, you have to travel through the Hall of Mat. And there are a number of gods helping you through that process. So there is one that puts your heart on a scale. So you can see the heart is on a scale, and the other side is a feather. And there is another heart here, another god, who is recording this. And if your heart is as light or lighter than a feather, then you succeed and made into your afterlife, and you have another god accompanying you into the afterlife. However, if you fail that test, that god here, Amut, he has the head of a crocodile and is ready to eat you up, and that's the end of you. So the heart is where the soul resides. But the heart also is the organ where essential human emotions and virtues resides. And if you take an example now from India, the little space within the heart is as great as a vast universe, or it is only with the heart that one can see rightly what is essential, is invisible to the eye. That's from the Petit Prince, Antoine de Saint-Exupéry. In addition to that, parents are aware of the very rare cases of sudden death in young athletes, because invariably the news media is going to pick it up. And it's going to be, is a tragedy. You have those healthy, dynamic people who suddenly died during playing sports. So invariably that makes it to the news, people are aware of it, even though this is very rare. If you look at the incidence of sudden death in young athletes, is about 1 per 2,500,000 high school athletes per year, okay? And if you compare that to the risk of other causes of accidental death in adolescents in the US, you can see that sudden cardiac death is much less, is half as frequent as being struck by lightning. And of course, doesn't compare with the risk of dying from a vehicle accident or drowning firearms. So very rare, but a tragedy. And the role of the primary care provider when we do the sports physical is to make sure that the child or the young adult doesn't have a cardiac condition that can cause that. So again, if you look at the major cause of death in children and adolescents, you can see that heart disease is not on top, okay? Motor vehicle accident, firearm, cancer, all that comes way before heart disease. But what are the causes of sudden death in competitive athletes? And so, this is to keep in mind. Half of them basically are from hypertrophic cardiomyopathy. So that would be really one of the big focus when you do sports physical. Are there any suspicion there of potentially hypertrophic cardiomyopathy? The other one are more rare than hypertrophic cardiomyopathy. The next one would be coronary heart disease. And in children, it mainly is going to be coronary artery anomalies, congenital anomalies, and as you get older, coronary artery disease. And then the next one would be rupture of the aorta. So we'll go a little bit about the sports physical and how we suspect those conditions that can cause sudden death. So sports physical, there are different, in your different rotations, you may see different forms, but I chose one here that is called the pre-participation evaluation. And this was developed together by the American Academy of Family Physicians, American Academy of Pediatrics, American College of Sports Medicine, American Medical Society for Sports Medicine, the American Orthopedic Society for Sports Medicine, the American Osteopathic Academy of Sports Medicine. So you can see this is really lots of the people who are involved in sports and medical care in that context. Now, many of these recommendations comes from studies that have been published by cardiology journals, and so the American Academy of Pediatrics is mentioned there, but the cardiology, American Heart Association, and all that were part of that as well in designing the studies. But I don't know what questionnaire you have seen, but basically after the general questions, you can see you go straight into the heart health questions. So have you ever passed out or nearly passed out during or after exercise? Because that would be a big red flag that there may be a problem. Again, have you ever had discomfort, pain, tightness, or pressure to your chest during exercise? Another red flag. Again, does your heart ever race, flutter in your chest or skip beats, especially during exercise? Again, that's those three things. In terms of syncope, pain, and palpitations during exercise are red flags, okay? Has your doctor ever told you have any heart problems? And did you ever have a special test like an ECG or an echocardiogram? And then there are also health questions about the family. So has any family members or relatives died of heart problems or had an unexpected or unexplained sudden death before age 35? Then they ask about genetic conditions. So in your family, does anyone have a genetic heart problem, such as hypertrophic cardiomyopathy, Marfan syndrome, arrhythmogenic ventricular cardiomyopathy, short QT syndrome, and so forth and so on. For most people, that would be like foreign language, but if someone in the family has had it, they may have heard about it, okay? And as anyone in your family has a pacemaker or an implanted defibrillator before age 35. And then you go to the physical exam, and in the physical exam, they stress the appearance looking for signs suggesting Marfan syndrome, and that's kyphoscoliosis, high arch palate, pectus excavatum, arachnodactyly, hyperlaxity of the joints, myopia, mitral valve prolapse, aortic insufficiency. And then, of course, you do a full exam, but with a special space here for the heart exam, listening for murmurs and things like that. So let's talk specifically about hypertrophic cardiomyopathy. You see it is 50% of cause of sudden death in athletes. And so we need to know a little more about it. So in the normal heart, the sarcomere is formed with perfectly aligned thin and thin myofilaments. So that's the way it looks schematically. And then on the A slide here, this is the way it looks microscopically when you look at one heart sample of the heart muscle. And in the cardiomyopathy, the cardiac myocytes are enlarged with bizarre shapes. They are disarrays. We give them a swirling appearance of the myocardial architecture. And so hypertrophic cardiomyopathy is characterized by multiple pathological features, including myocyte hypertrophy, disarray, and interstitial fibrosis. So you see the difference in the way it looks microscopically between normal and abnormal. Okay, how do I go to the next slide? For some reason, it's not moving here. Christine, someone. Okay, there we go. Okay, hypertrophic cardiomyopathy, again, it is autosomal dominant. So usually a parent, I mean, there are occasional spontaneous mutations, but usually it is transmitted by one of the parents. Now, the problem is that it has very variable penetrance. And you may have patients with hypertrophic cardiomyopathy who are aware of it early on, who have problems right away, who need surgery very early on. And you have other people, it's not detected until they are older. For instance, they go for prostate surgery and the anesthesiologist wants to get an electrocardiogram before as a routine and find out it is abnormal, then gets an echocardiogram, and sure enough, the patient has a hypertrophic cardiomyopathy. So very, very different penetrance, that's the problem. But again, as mentioned before, it's important to ask if that is in the family or if there was any sudden death before 35 years of age. And as you can see, in hypertrophic cardiomyopathy, most of the time you have thickening of the myocardial, especially in the left ventricle, and that is often going to cause an obstruction of the atrial tract, turbulence into the atrial tract, causing the systolic heart murmur. And the systolic heart murmur, contrary to the innocent heart murmurs that you hear usually, is going to be louder in the sitting and standing position. And also, when you do the Valsalva maneuver, usually for innocent murmurs, they they are louder in the supine position and softer in the standing position. Is reversed here with hypertrophic cardiomyopathy. The same with Valsalva maneuver. In innocent murmur, it makes it softer, and in a hypertrophic cardiomyopathy, makes it louder.
You just have them hold their breath and bend down when you do that, when you listen, when they do the Valsalva.
That's the Valsalva maneuver.
But that's what it is, right?
Yeah, Valsalva maneuver, you take a deep breath and then you pretend you are blowing it out, but you keep it in. And so in innocent murmurs, usually that will,
You don't.
yeah, that will make it softer. Strangely enough, in hypertrophic cardiomyopathy, it makes it louder. And so the symptoms again is chest pain, palpitations, or fainting with exercise. So with exercise, any of these symptoms is a red flag. You need to address it. Now, even in primary care practices, in clinics, you are usually going to be able to get an EKG. So if you have the situations, you are going to get an EKG, and usually it is abnormal with deep Q waves and abnormal QRS complex and ST segment. Now, coronary arteries abnormality in children, again, most of the time are going to be congenital. So that's an abnormal origin of the coronary artery or abnormal course or abnormal branching. The acquire is going to be is going to rarely occur. Once in a great while it may happen, but it is very, very rare in children. As young adults start getting that more and more. So how do you suspect these conditions? Well, of course, if there is a family history of early coronary artery disease, that would be a red flag. Again, the same thing, chest pain and syncope with exercise would be a red flag. And that will have also often an abnormal EKG. Of course, you may also want to consider a lipid panel, see if you are not dealing with hyperlipidemia. Now, rupture aorta, this is what happened with patients with Marfan syndrome. That's why in the physical form here, in your sports physical, there is so much emphasis of trying to figure it out if the patient has Marfan syndrome. So again, there are other connective tissue disorders, but the most frequent is Marfan syndrome. So you do the best you can in looking at all the signs we looked at, cleft palate, pectus carinatum or excavatum, scoliosis, and then long arms and very, very loose joints. There is a thumb sign that you can do. Many different ways to suspect that. Now, let's talk about a little bit about COVID-19. Why is that different? Well, COVID-19 in children is usually mild. They either have no symptoms, mild symptoms, and they recover. That's the vast majority. The problem is that if you look very, very carefully, even in young athletes who have COVID-19, you study them intensively, you're putting them on treadmill, doing echocardiogram, getting a Holter monitor. You find out that a little less than 3% have evidence of myocarditis or pericarditis. Now, usually it is very benign and usually it resolves on its own, okay? But you don't want to allow children to play sports when they have an ongoing myocarditis or pericarditis. Now, of course, there are exceptional cases. They are going to be very sick with COVID-19 and they are going to be admitted to the hospital and to the ICU. If that is one of your patients, I would let the cardiologist decide when they can return to sports, okay? But you can talk about in the primary care clinic, most of them are going to be asymptomatic, and by and large, there is no recommended testing at that time. I would say I would not recommend doing sports during the first couple of weeks after the acute illness, but if someone is asymptomatic, there is really no need to go further, okay? Now, if the child is symptomatic, mild to moderate, then it is safer to evaluate the child and introduce what we call gradual return to play, okay? So for the mildly symptomatic, mild to moderate, it's not a bad idea to get an electrocardiogram and maybe get troponin. So that's what you can do in the clinics, right? You can order a troponin, you can get an electrocardiogram. So if it has been a few weeks, the symptoms are gone, normal exam, and the child has normal EKG and troponin, I think it is okay to go back to sports. And you may want to use gradual return to play. I will show that on the next slide. Again, for the severe illness, as a primary care provider, I would not recommend for you to be involved because, they have this multi-system inflammatory syndrome and the heart can be really affected and you don't know what medications they gave and what the side effects would be. So I would leave that for the tertiary center, multi-specialty teams to decide when the child can return to sports. And so gradual return to play, is basically, there are different, I chose this one here. This is in up to date, you can find it. It's different stages, and you based it on the maximum heart rate, and then you increase slowly the amount of exercise. Okay, so I would say in primary care practice, you will rarely have to use this, but if it is a child who was mild, but either has symptoms or abnormal screening tests like we talked about, I will definitely use that before they return to normal. However, if it is anything abnormal, I would recommend you send them to the cardiologist to have further evaluation. They probably need to have an echocardiogram. They may need to have a Holter monitor, a treadmill test. They will decide what needs to be done. An MRI, cardiac MRI, whatever is necessary to make sure it is safe. Now, the rest of time we have, in the primary care clinic, you are going to encounter all the time children with heart murmur, children complaining of palpitation, syncope, and chest pain. And so what are in your mind, at least in my mind, that's the way I think about it, what are the potential causes for that? And I like to put it into different categories. Is that a congenital heart disease, or is that an acquired heart disease? Is that due to an arrhythmia or genetic syndrome? So I try to figure it out that way. And before the next slides, I want to specify, I mixed up the two words, incidence and prevalence, and they mean different things. So I'm putting the definitions here. Incidence refers to the number of new affected persons per unit of time of population. Prevalence refers to the number of affected persons at any time. So slightly difference here, but we go, okay. So if we look at the incidence and prevalence of heart disease in children, so congenital heart disease is a little less than 1%, okay? Now, that does not include bicuspid aortic valve. Bicuspid aortic valve is a congenital heart disease, but the reason it's not included there is that usually, in most people, they have mild bicuspid aortic valve with no obstruction or no insufficiency. It may not be detected in childhood at birth and so forth. So that's why it was not introduced. It should be really part of the congenital heart defects. Now, acquired heart disease, nowadays, the most common is actually Kawasaki's disease, but you can see this is not terribly frequent. A quarter of them will have a cardiac complication, and is only 0.1 per 100,000 children who get that. So acute rheumatic fever used to be the #1 acquired heart disease, but now with the proper treatment of streptococcal infection is much more rare than it used to be. And myocarditis and pericarditis can occur also, but they are fairly rare, okay? Now, the arrhythmias, I want you to see that the one to think about is long QT and WPW, both Parkinson-White. And you can see that they are rare, but not excessively rare, right? And so this is why we get an EKG when there are palpitations or fainting with exercise or things like that, because you want to exclude those two conditions. And you can do that in the primary care setting by getting an electrocardiogram. You will see that. Now, the genetic syndrome, the most common is hypertrophic cardiomyopathy. And this one may not show up. You may be the one detecting it, either because of symptoms during exercise or because listening to a heart murmur and then doing a little workup in the clinic and seeing that the EKG is abnormal and making a referral for the echocardiogram. Now, the Down syndrome, that is usually going to be detected either before birth or at birth, and the child will be evaluated for heart disease. So that wouldn't be up to the primary care provider to make the diagnosis of heart disease. Turner syndrome, again, most of the time will be detected early, but not all the time. But it is fairly rare. But if you have a young girl that's not growing very well and then has some unusual features and then daily menstruations, you may want to think about that. Marfan syndrome, we talked about it. We definitely need to think about this when you do the physical exam before sports. So again, if we talk now about the congenital heart disease, congenital heart defects, the major congenital heart defects are going to be detected either in utero or shortly after birth. Okay, so we are not going to talk about here about transposition of the great arteries, tetralogy of Fallot, all these conditions that are usually detected either before birth or shortly after birth. But there are many children with congenital heart defect, and they are not detected in the nursery, and they leave the hospital after birth. And it is up to the primary care provider to be the one suspecting the congenital heart defect and making the diagnosis, at least suspecting the diagnosis, and then referring to the pediatric cardiologist. So, I mean, there are a long list of congenital heart diseases that the primary care provider may be the one suspecting. But we are just going to select a few today, the most common, and I put them here by alphabetical order. So we talked briefly about aortic valve stenosis and bicuspid aortic valve, atrial septal defect, coarctation of the aorta, PDA, pulmonary valve stenosis, and VSD. Okay. So how do we detect these things? So let's go first to aortic stenosis. Okay. It's about 6% of all congenital heart defect. Okay. And again, how do you suspect this? The mild cases are going to be asymptomatic. And of course, the critical and severe are going to be detected in the nursery. So what you will hear is a systolic ejection click at the apex and or the left lower sternal border, and a systolic ejection murmur at the base with transmission to the neck vessels. Okay, so we can maybe try to listen to that. Hopefully it will work. So here what you hear at the apex is a systolic ejection click. So you really have to focus on that first, normal kids listening to the first heart sound and then comparing to a child who has a systolic ejection click. And then you have at the base the systolic ejection murmur. Okay? And that murmur typically is transmitted into the neck vessels. Okay, so basically, when you hear a murmur at the base going into the neck vessels, and then you listen at the apex and the left lower sternal border, and you hear an unusual little noise there, that's a click, then you need to refer to cardiology to be evaluated. Atrial septal defect, again, is usually not detected early on in the nursery. And eventually what happened is that you have lots of blood coming from the left atrium going into the right atrium. So the volume of blood going into the right ventricle becomes like twice, we call them QPQS 2:1. That means twice the volume of blood going through the lungs and to the body. And so that increased volume caused turbulence across the right ventricular outflow tract. And so what you would have for an atrial septal defect, you palpate the heart always, and you would feel that the RVM pulse is increased. That would be along the sternum, instead of the apex, you would have really a prominent impulse there, okay? And then you listen carefully to the heart sounds, and you will have a normal S1 usually, but widely split fixed S2, okay? So normally S2 varies with respiration, but there it will be widely split and fixed. So we'll hear about that. And you may want to do this in the sitting and standing position. In ASD, that's where you will be more likely to be able to detect that. And then you will have a systolic ejection murmur at the base. And that's, you know, it doesn't sound very impressive usually. And then if that's the case, you will order an electrocardiogram. And again, it may show a right ventricular conduction delay. The problem, this is found in most kids with ASD, but it is also found in normal children. So, but if you have a murmur, you know, increased RVM pulse, a murmur at the base, you know, right ventricular conduction delay or RVH on the EKG, and on chest X-ray, if you see increased right atrium or main pulmonary artery like this, definitely you would refer to cardiologists for further evaluation. So how does it sound? This is a split second sound. It's very soft. I don't hear. I don't know if you hear it. Yeah, if you listen carefully, you can, but it's too soft. Okay, coarctation of the aorta. So this is definitely a condition that you as primary care providers are going to be the one detecting, okay? And it is simple because it has to do with abnormal pulses. And so if there is a message that you want to remember from this conference here, is that it's very important to feel the pulses all the time. When you do a physical on a child, you feel the pulses. And the way you feel the pulses, you feel them first in both arms at the same time. And the reason you do that is that often you have aberrance of subclavian artery. It may be at the site of the corax or even below the corax for the left subclavian. And so you have a difference between the right and left brachial pulses. So that already something is maybe wrong if there is that. But it's good to know because you are going to then take the blood pressure in the one in both arms, but the one that you are worried about is the one with the highest pulse, right? So the stronger pulse. And then after you have done that, selected the pulse with the stronger pulse in the arms, you take at the same time the pulse, the radial pulse in that arm, and then in the femoral pulse. You do it together. And normally, you know, they occur about the same time, but in coarctation, they will be weaker in the femoral artery and they will be delayed, okay? So that would be a red flag for you. And then you would take the blood pressures, both arms, and then the arm with the highest pulse and pressure with the femoral in the legs as well. And if you have a gradient, the child needs to be evaluated, okay? Now, you may have a systolic murmur also in the back or at the base if it is combined with aortic stenosis. And the systolic ejection, often they will be associated by cuspid aortic valve, so you may have a systolic click as well, okay? So again, that's the message here. Always take pulses in both arms and then in one arm and in the legs. And then if there is anything suspicious, take blood pressure in the arms and in the leg. PDA, 3 to 8% per 10,000 live births, so it's fairly rare. It's more frequent in girls. And it could be present in different genetic syndromes, so sometime by itself. And you would suspect that because of prominent pulses. For large PDA, it would be bounding pulses, and it would be a continuous heart murmur. So you usually hear best in the left infraclavicular region, in the axilla, and in the back. So, you know, continuous murmur that needs to be evaluated further. Valvular pulmonary stenosis is fairly rare, so we won't spend too much time. You will have again a systolic ejection click, and the systolic ejection murmur at the base that would be best heard in the second left intercostal space with occasional transmission to the back. EKG may be normal in mild case, RVH in more severe case, and the chest X-ray may show a prominent main pulmonary artery. Okay, ventricular septal defect is one that you also are going to be detecting in the outpatient clinic. The small ones, of course, the large one may have been detected in utero, but for the large ventricular septal defect, you may even be the one detecting that, because what happened is that when you have a big defect, the pressures are equal between the right and left ventricle, and there is a delay in the drop of the normal drop in pulmonary arterial pressure after birth. So the murmur may not be apparent for several weeks until the pressure drops into the pulmonary arteries, and then you start hearing a murmur. So the primary care provider may be the first one to hear that murmur. Okay. So, and it's the same for small VSD. So for small and large VSD, the primary care provider may be the first one to diagnose that. And for the large VSD, it could also be a failure to thrive. You know, before even there is a murmur, the child is breathing a little fast, is sweating, is not growing too well. And so that could be sometimes because of a VSD. And then later on, when the pressure drops more in the pulmonary artery, you hear the murmur. So typically, it is a harsh holosystolic murmur at the left sternal border. And the EKG may be normal in small VSD and maybe abnormal, but there are different patterns depending on the location of and the size of the VSD. So definitely, if you hear a harsh pansystolic murmur, you are going to want to refer the patients to a cardiologist. Again, you can most of the time reassure the parents that, you know, it sounds like a VSD, but this is a type of thing that close by itself usually and not to cause problem, but it needs to be evaluated by the cardiologist. So let's try to hear that. So this is a harsh pansystolic murmur. It means from between S1 and S2, you hear. Okay. All right. So in summary, and then we leave some room for some questions that you may have. Okay, most of the time when you evaluate the child, you will be able to reassure the parents, okay, and the child. And especially if you check everything. The growth and developments are normal. There are no symptoms. There is no family history of heart disease. If you hear a murmur, it's consistent with an innocent heart murmur. And that is a musical murmur that's louder in the supine position, okay? If you have normal vital signs, weight, height, if child is growing normally, blood pressure in all extremities, oxygen saturation, and symptoms suggest a non-cardiac cause. For instance, example, chest pain after eating, or the syncope after a sudden change in position, or palpitations during stress. Most kids who have palpitations is because of anxiety and stress and their heart rate going faster. And then, of course, you know, if you have any doubt or if you want to be reassured, you may want to get some screening test, EKG, chest X-ray as needed. And then if all that comes out in the right direction, you can reassure the family, the child, and the parents, and then arrange for follow-up in the clinics. Now, we have to be aware of the red flags, okay? Symptoms, of course, shortness of breath, tachypnea, diaphoresis, chest pain with exercise, all those are going to be red flags. Family history of heart disease, of early death, okay? So, of course, if there is a diagnosis, that makes it easier. But if it is just, we don't know Unfortunately, he died when he was 34. That's a big red flag. And then suspicious finding on physical exam. If you hear a click, if you feel a thrill, if you have a diastolic or continuous murmur, if you have weak femoral pulses, all this will raise questions that maybe there is something more serious that needs to be explored here. Abnormal vital signs, for instance, the low oxygen saturation, of course, that would be a big red flag. And then symptoms suggesting possibility of cardiac cause, chest pain, palpitation, and syncope during exercise. We went over there, and then abnormal screening test. And then I will add to this the troponin test if you do in the context of the ruling out myocarditis after COVID-19. Okay, so in summary, most children who have a heart murmur have an innocent heart murmur and no structural congenital heart defect. Most children who have palpitations have anxiety and a normal heart. Most children who have chest pain have a non-cardiac cause for the pain. And most children with syncope have a normal heart and no significant cardiac rhythm problem. But before we, as primary care providers, come to that conclusion for our patients, we need to explore carefully to make sure we are not missing any of the cardiac diagnosis we talked about. So I think we have a few more minutes for questions. I can stop here, maybe the thing, and stop the sharing and open to questions. I don't know if you have questions in the chat. Maybe Christine, you can see.
We have 2 so far.
Okay.
Okay. When asking family cardiac, I got this word, history, sudden death before age of 35 and MI before the age of 50, when do you refer for further evaluation? If it was a grandparent, cousin, aunt, uncle, parent, how far out do we ask?
Well, I would definitely go to the direct family members. I mean, it's more questionable when it is a third cousin or aunt and uncles. But if it is parents and grandparents and siblings, I would definitely take that seriously and go further. Take a careful history. I would say you get depending. If you are not sure what it was, you get a lipid panel. You get an EKG, and go from there one step at a time, and then refer if it is anything abnormal. Yeah.
Regarding myocarditis associated with COVID vaccine, what are you seeing in the incidence of this? Should we be asking any different questions of kids who did not have COVID but had vaccine other than SOB and chest pain? Shortness of breath and chest pain?
Yeah, so that's a good question. In the media, they talked a lot about the risk, and it was picked up by people who are against vaccination and things like that. The actually incidence of myocarditis after vaccine is about 6 times less than it is from the COVID-19 infection. But it does occur, and it does occur usually in teenagers and young adults, and mainly in male patients. And so again, it's going to be a mild myocarditis. It's usually going to resolve on its own. It's usually not cause problems. But you definitely don't want to play sports, especially competitive sports, if you have that. So I will just take a careful history. If people have any of those red flag symptoms after, usually it can happen, a few days or a few weeks after the vaccination. So if there are any symptoms, I would definitely get the EKG, the troponin, wait for doing sports until that is all normal. If any suspicious or any doubt, you send them to the cardiologist so they can do an echocardiogram, maybe a treadmill test, whatever is necessary to make that diagnosis. But again, it is rare. Most of the time it's very mild, and resolve by itself.
Do we have any more questions? You can unmute yourself if you want to just ask the question directly instead of typing in.
I see. Nothing here from the residents.
Okay, very good.
All right.
Well,
Thank you,
wishing you
Dr.
the best.
Rogé.
Thank
I
you,
don't-
Dr. Rogé. That was awesome. I appreciate it.
You're welcome, and I wish you the best in your practice there. And don't hesitate to call the cardiologist when you have any questions. You know, you discuss the cases. Yeah.
All right. Thank you so much, Dr. Rogé. If you would like
You're
to
welcome.
sign off, you're good to go.
Okay,
Everybody at
very good.
El Rio will start our break now, and we can start at okay, it'll be 11:02 my time, so 9:02 for you guys for next session. All right. Bye, Dr. Rogé. Hi, Dr. Leggett-Johnson.
Good morning. How are you?
I'm good. How are you?
I am doing great.
Wonderful. So El Rio just finished their first session. They're going to take a 10-minute break so we can start at 11:02. You're East time, right?
I am.
Okay, perfect. Me too. But I have to. They're in Arizona, so they're going to be back in 9 minutes.
Okay. All right. And
I
oh, I see the
Yeah.
that's nice to see them down
Yeah.
there.
So yeah, so this one you actually be able to. They'll turn their cameras off while you're talking, and then when we do the Q&A, they can turn it back on or whatever. But you know what? Hello, my name is Kristen Talbot, and I am the program coordinator for the MAVEN Project. Thank you to our friends at El Rio for hosting today's session on FMLA with Dr. Leggett-Johnson. Dr. Susan Leggett-Johnson is an established and highly skilled practitioner with more than 30 years of experience providing exceptional care to adult patients as an internal medicine physician across Maryland, Virginia, and the District of Columbia. She obtained her medical degree from Louisiana State University of Medicine in New Orleans. She completed her residency in internal medicine at Howard University Hospital in Washington, D.C., and later obtained a Master of Business Administration from Selinger School of Business, Loyola University. In addition to patient care, Dr. Leggett-Johnson served for more than a dozen years as a healthcare executive in a large medical organization, along with chronic disease management. Her areas of focus include employee health and wellness, mindfulness, resiliency, diversity, inclusion, and professional development. She's been recognized for both of her excellence in patient care as well as her skills as a healthcare executive. Dr. Leggett-Johnson is a member of the American Board of Internal Medicine and holds active licenses in Maryland, Virginia, and District of Columbia. She resides in the suburbs of Maryland with her husband, works independently as a healthcare consultant, enjoys life with their 3 children and grandchildren, and also volunteers for the MAVEN Project. Dr. Leggett-Johnson, when you are ready, please begin.
Thank you so much, Kristen. And it's a pleasure to be here today. I want to welcome all of you to your careers in medicine, and I hope that you have an opportunity to enjoy yours as much as I have mine. So you've heard a little bit about me. I have nothing to disclose. And you will receive CME credit, perhaps. I will leave Kristen to answer that at the end, but this presentation does qualify for CME. Family and Medical Leave Act. Many of you have heard FMLA. So we will talk about Family and Medical Leave Act and the clinician's role. So we will look at details of the FMLA Act, describe the clinician's role when you're completing the forms or the certifications, discuss the intersection between FMLA and disability certifications, and talk a little bit about the clinician-patient communication skills when you have to deny an FMLA request. Now, this presentation is dense, and I will skip over a number of the slides and focus on some of the topics and points that I think are critical to make for you today. You will get a copy of this presentation so you can review any slide I may have skipped over at your own convenience if you find useful. So let's talk about FMLA. There are some common things that people think when they think about FMLA that are just not right. They're dead wrong. Here are a few. If a patient uses sick leave, the employer will require an FMLA form to cover the sick leave. That's not true because not every sick cause qualifies for FMLA. Maternity leave is always 3 months. That's not true. It's dependent on the state. For the most part, it's 3 months, but it is state dependent. If I, as a clinician, don't sign an FMLA form, regardless of the illness, the patient will lose his or her job. That is not true. Clinicians make the decision regarding FMLA, or clinicians approve FMLA. Also not true. And leave covered under FMLA is in addition to available sick leave. Not true. So let's talk about why those things are not true. The Family Medical Leave Act provides eligible employees up to 12 of the employee's work week, and that's in a 12-month period. That 12-month period rolls, meaning if you're looking at March to March, because we're in the month of March, or June to June, because we're in the month of June, it will provide 12 weeks of employees, work weeks as FMLA eligibility if you qualify. FMLA can be taken, consecutively, but a lot of people don't realize that you can take FMLA intermittently, meaning you can have a reduced schedule, or you can have 2 days off per week, or you can have a half schedule and be off just half a day. That would be similar to a reduced schedule. Reduced schedule could also mean seeing less patients in the time that you are working, if you are a clinician, for instance. It's available for an employee who requires time off for serious health condition, and that's if he or she cannot perform the functions of his or her job. Because that person has a serious health condition does not mean they qualify for FMLA. There's something that's called work accommodations. Perhaps work accommodations can be made. So it's not a slam dunk. Of course, for the birth of a child, for females, and also for males as the male parent, but at a reduced amount. Care of the newborn child during the first year, if there are issues, of course, and care of a family member who has a serious health condition, and the employee, the person requesting the FMLA, is needed to care for that family member. Also, care of a child who's placed in adoption or foster care in your home or the patient's home. They may qualify for a limited amount of time off for that reason. It's also available to deal with qualifying issues related to the spouse or child or parent of someone in the military. We're not going to talk specifically about that, but just know there are some qualifying issues. Care for covered service member who's a spouse. We won't talk about that, but just know there are some special criteria if you are a military, active military person or a veteran, and that would have to be looked into. You don't have to know all of that. The patient usually will present the FMLA form and provide you with additional information. Where do they get the information? Usually from their HR department. HR plays a significant role in looking at FMLA form. For 12 years of my career, actually 11, I was the head of our HR department for a large medical group, and I had the opportunity to look at FMLA requests for our own staff and employees during that period of time. I also had the time to address what was going on with our patients as a clinician, but also training our physicians and nurse practitioners how to correctly fill out an FMLA form. Please know that FMLA provides time off and it entitles the person to come back to that same job or a similar job, but it does not provide additional paid leave, should I say. It provides unpaid leave. What do I mean by that? What I mean is that if you apply and qualify for the Family Medical Leave Act, and you turn that form into the HR department and it is approved by the HR department, you may be able to use your sick leave, your vacation for the time that you are out. If you run out of sick leave that's available to you, if you run out of vacation leave, you can still stay home and deal with your issue, but you may then roll over into unpaid leave. So you will not be paid during that period of time you're out if you've run out of benefits. However, your job is still protected for that period of time that we talked about, 12 weeks. You also will continue to maintain other types of benefits while you're out, unless there are policies that suggest otherwise. For instance, when people are out on leave, if they're using vacation or sick, they will still accrue, their vacation hours or sick hours, etc. But if they are out on unpaid leave, they will not continue to accrue vacation and sick leave during that time off. It's based on your employer's policy, but just know there could be some changes. You may also not accrue other benefits like time toward retirement, etc. As a clinician, you don't have to know all of that. I'm just making some statements that there are a lot of things involved behind the door when we're dealing with FMLA. And I want to let you know that unless there are specific situations, employees are entitled to return to their original position or an equivalent position that pays similar. And they only have to have a 2-day notice that they're coming back. So this is important. Who determines eligibility for FMLA? You don't as a clinician. Physicians, nurse practitioners, physician assistants, specialists do not determine eligibility. The HR department does. The employers determine the employee's eligibility. There are certain criteria that come into play. You must have worked 1,250 hours during a 12-month period of time. That's around 6 months. You have to have worked 6 months during that year in order to even qualify. Oftentimes, if you're new to a position, you have to have worked for 1 year to qualify for FMLA. So employers have that information. They know that information. They determine if an employee or family member's condition meets eligibility criteria. They look at the information that's provided in the medical certification form. That's where you come in. You complete the medical certification form as a healthcare provider, and the employer will determine whether or not it qualifies. They may delay or even deny the FMLA in the certification, especially if it's not filled out completely, or if the information doesn't fit the qualifications. So A lot of times what I hear from clinicians are, do I have to fill this out? Why can't someone else do it? I'm the primary care clinician. Why can't the specialist do it? The person had, migraines and is seeing the neurologist. Why can't the neurologist do it? I would say that the neurologist could complete an FMLA form, but in most of the organizations that I'm aware of, the primary care clinician completes the FMLA form. It's just the way it is. It's just what's expected. And so as a primary care clinician, oftentimes it will come to you to be completed. Many times specialists will send it to you, even if the member sent it to their specialist. It may not always be the case, but just know that may be the case in many organizations. So as a clinician, what do? Well, you need to know and understand a little bit about the rules of FMLA. You need to understand that you don't determine whether an employee is eligible for it. And so you can't guarantee anything to the patient. All you need to do is complete the form timely and fully so that the patient has the best chance of qualifying for FMLA. Their certification must be completed by a healthcare provider, and it certifies that the employee or family member meets the statutory requirement regarding a serious health condition, the ability to perform the functions of a job, the intermittent or reduced schedule is medically necessary, and leave is needed to care for a family member or a serious health condition who has a serious health condition. Those are the areas in which you are certifying. Now, those serious health conditions are already determined. You can't all of a sudden say, I wonder if this condition will qualify as a serious health condition. You don't need to do that. There is a list of things that have already been determined qualifying as a serious health condition. And there's a list available to you. You can look it up. I included it in the slide. In the form, it will ask you, did inpatient treatment occur? Meaning, did the patient stay in the hospital or hospice or some residential medical care facility overnight? Is continuing treatment by a healthcare provider, whether that's you or someone else like physical therapy or specialist, required? Is there an expectation of a period of incapacity for more than 3 calendar days? Those are the things that you will need to complete in the form, including whether or not subsequent treatment or incapacity is required or expected. So you have to have 2 or more treatments by a healthcare provider, within 30 days of the onset of the capacity, or 1 treatment by a healthcare provider, which results in a regimen of continuing care. That's what they mean when they mean continuing treatment by a healthcare provider. Definition of a serious health condition also includes any period of incapacity due to pregnancy or prenatal care. A chronic condition that may cause periodic rather than continuous periods of absence. For instance, someone suffering from a migraine headache may not have a migraine headache every day for 2 weeks, but they may have a migraine headache that will cause them to miss work 2 or 3 days out of the month, and that might occur 3 months in a row or 4 months in a row. So that would qualify as a serious health condition with intermittent absences from work, and that person would be protected under FMLA. But you also want to think about continuous treatment by a healthcare provider for permanent or long-term conditions. And I'm talking about things like cancer or stroke or heart failure. Those things would qualify. Also, restorative surgery after an accident, a car accident where you need to do a number of things to get back on your feet. To control a condition that may require 3 days of absence of treatment, such as chemotherapy or radiation for cancer. Once you have chemo, you're not feeling well for a couple of days after, and you may need the day of treatment and 2 days after before you can return to work. That would be an example. So here's a list of possible serious health conditions. And I say possible because it depends, but it has to qualify based on when it was diagnosed, how much time off is needed, the things that we just talked about. But here's a list for you to think about. Treatment for alcohol and drug abuse. People don't think about that. We already mentioned pregnancy, but pregnancy complications, for instance. Migraines, that's one that people don't think about a lot. Some of the others are pretty much no-brainers, right? Pharyngitis, so that's a common one. So possible, it depends on what the cause of the pharyngitis is, right? If it's strep pharyngitis, you wouldn't expect people to get strep pharyngitis frequently enough to qualify for FMLA. For instance, if you treat them with antibiotics, they should be able to go back to work within 24 hours of starting the antibiotic. So you wouldn't be off 3 days, similar to a flu. For the most part, people only need 3 days off at max for flu. So they wouldn't require more than 3 days. So flu usually does not qualify as a serious health condition. But pharyngitis, where you need a tonsillectomy, or you have mononucleosis and you have severe fatigue and you're feeling really ill, maybe that would qualify. So things that are not considered serious health conditions, I just want to mention here because they come up a lot. Your colds, your stomach aches, your flus, minor ulcers. The other one had ulcers, but we're talking about bleeding ulcer, hospitalization, things like that. Earaches, headaches that are not migraine headaches. Routine appointments, getting your dental work, even if it's cosmetic treatment, you're getting braces, you need to do this or that. Absences due to substance abuse, different from treatment from substance abuse, where you can actually document the treatment. Absences because you overindulge does not qualify for a serious health condition. So you have to complete the medical certification, and just know that a stated diagnosis is not required. You do have to fill out the forms. All of the forms, regardless of where you are in this country, will ask the same questions. They may look a little different. Many of them actually look exactly the same, but they may not, but the questions will be the same. So you have to put the information that's requested, and it will be information relevant to the identifying whether there's a serious health condition. It will ask whether or not the person was hospitalized, if so, how many days. It will ask how many days the person has been out and will need to be out. It will ask your information, name, location, practice, specialty, etc. You will have to describe symptoms, treatment, whether or not the person will need ongoing treatment with other specialists, and the date in which all of this started and how it impacts the job functions. Remember, some people can have a medical condition but can continue to work. For instance, someone with Crohn's disease, having a flare-up and requiring frequent bathroom breaks. Maybe a work accommodation can be made for the bathroom breaks, or maybe a work accommodation can be made for the person to work from home. It may not require time off from work. So additional information required on the medical certification, whether or not the leave is continuous, whether or not the leave it should be intermittent or just a reduced schedule, whether or not there is expected episodic flare-ups, explanation as to whether it will be medically necessary for the person to be completely absent from work during those flare-ups, and frequency and duration of flare-ups to the best of your ability. Okay. Now, just know, I mentioned this already, an employer can deny FMLA if the medical certificate does not contain information that is relevant or is incomplete or is missing some information. It may be denied. And the employee will be notified that it's denied. Also, I want you to know that they have 7 days to correct any deficiency. So if you, as a provider, completes an FMLA form and the patient says, my employer said it's not complete, there's not enough information, you didn't answer question number 4, whatever, just know they have 7 days to get it back. So oftentimes we put this on the desk and we forget about it. You will put that person in a situation where more than likely the FMLA time off will be denied. So just know that if the FMLA is denied, then there is an increased risk of that person losing his or her job if he took time off that was not approved for FMLA, because the job is then not protected. Just know, just on this slide, I'll mention that an employer has the right to ask for medical clarification. Some people get really suspicious when the employer calls the healthcare provider to clarify some information or sends a letter for clarification. Know that they have a right to do it. However, it is the employer's responsibility to get the HIPAA compliant authorization form completed that allows them to reach out to you, completed by the employee. So they have to get the employee to sign verification that it's okay to contact you before contacting you. So what you need to know, if ever contacted, is, do you have a HIPAA compliant authorization for me to disclose the information? That's what you need to know. And if they do, yes, they have a right to ask for clarification. Not additional information, but clarification on what you already provided. So here are some cases. I really, for the sake of time, won't go through them, but I'll just mention this one just to give you a taste. In this case, a patient was requesting FMLA for non-treated diagnoses, and the patient's condition was migraine, but the patient had no mention of it for a couple of years, and then all of a sudden they came in 2 days before requesting FMLA. The plan was to go to neurology, evaluate, confirm. Let's say that patient's new to you, you have no record of migraines. Perhaps they learned that that qualifies, so you're suspicious. Perhaps they do have migraines and they just hadn't had an attack for a long time. So that can come up, and you have to think about, well, you know, how do I play this? You look at the information. You see, you know, whether or not the person has been off, whether there have been previous FMLA requests. You just really try to get as much information as you can before completing that. And in some cases, it's not appropriate to complete it because the member just doesn't qualify. If you're in a situation where you don't know whether to tell the member, I don't think you qualify, or this condition does not qualify, like a flu, and I need you to, you can say that it doesn't qualify. Don't embellish on the FMLA form to try to get it to qualify. That would be inappropriate and wrong. Again, you know, something going on, no active treatment, requesting FMLA, doesn't look, and requesting 1 time per month for 7 days per episode. I wouldn't complete that with that history, especially with a shoulder dislocation that hadn't occurred for years. And just another example, which I'll skip over. There are some FMLA intersections. The employee may be covered by ADA, American with Disabilities Act, and workers' compensation laws. So it's not just FMLA that they may qualify for. I mentioned that sometimes a person will have a serious condition, but can return to work, but may do good with a reduced schedule, maybe working 7 hours or 6 hours a day, or moving a little bit slower, having a reduced production rate depending on the job. That would be considered a work accommodation. And so there is a separate work accommodation form that would need to be completed if the employee requested a work accommodation. You don't have to bring that up. They will come to you with a work accommodation form. That's all done with the employee and the employer. But just know they may have other qualifications beyond FMLA. And just like FMLA, the employer determines whether a work accommodation or workers' comp fit the bill. Okay, some differences in FMLA and American with Disabilities Act. The size of the organization. FMLA, you have to work for an organization with 50 or more employees. You know, a serious health condition, where with ADA, private employees with 25 or more have physical and mental impairment that limits a major life activity, not just like a migraine. And you have to have a record of such an impairment. So there are some differences. I won't mention the state, local, and federal government employees. That's a little complicated, so skip over that. And this is just something I want to mention. Simple things regarding FMLA and disability management, whether it's a work accommodation or ADA, regardless of what's going on, especially with the ADA and disability. Just know that the longer a patient is out of work, the less likely it is for them to go back to work when they're out on disability. So getting them back to work as quickly as possible is really important. That's why I put up here some simple principles for disability management. This is beyond FMLA. Activity is good, work is good, meaning get them back to work as soon as possible. Don't let the patient dictate to you how much time they need to be off and when they can and can't go back to work. There are criteria available to you that you can look up and determine what makes sense. You do want to make sure they can do the job, but just know patients will ask for as much as possible, and it may not always be appropriate. When to break rule number 1, when not to send them back. There are rules that will help you and principles that will help you determine that. And then, you know, when you have to do a time loss, and I'll mention these, return to work is good, and clinicians write activity recommendations. That's when you get those forms that say, how much can the patient lift? How much can they stand in the course of a day? Can they lift 5 pounds, 10 pounds, 20 pounds? Can they stand 8 hours because the job requires 8 hours of standing? Whether or not they can do those things. And then the employer will then determine whether or not it's appropriate for their job. The thing about disability management is if the work accommodation cannot be provided by the employer, and they do have a right and an obligation to try to make it work out, but sometimes it does not work out. The employee has a right to deny it based on business needs. So you are not involved with that. You just provide the accurate information that you have. Again, information about getting them back to work. The point here, a worker who has been off for more than 12 weeks has only a 50% chance of ever returning to work. By 12 months, the likelihood is about 2%. There's research out there that looks at how often people return to work. That is why long-term work absence and work disability is not a good thing. So you should only be completing forms like that, saying that if it's absolutely necessary. Here we're talking about 90% of the patients should have some ability to do some work. And you have to ask yourself, if your patient wanted to go back to work, would you let them? If the answer is yes, you should make that possible. Not the fact that they don't want to go back, but if they did, would you let them? So just think about it. Then it's your job to convince them that they're capable of going back. Because sometimes there are workplace problems that's keeping the employee from wanting to go back. Okay? And your role is to identify the impairment, identify the restrictions and limitations, and then the employer's role is to review that information and determine if they can make a work accommodation. Can they climb a ladder? Can they sit outside in the sun? Can they be exposed to dust? You have all of those kinds of questions. And keep in mind that if you say they cannot, whatever they cannot do has to fit whether they're in the work environment, in the home environment, wherever they are 24/7, 7 days a week. So if you say the person cannot sit for more than 2 hours at a time, then the person can't sit at home for more than 2 hours at a time either. If you say the person has to, avoid sunlight, they can't work outdoors, that means they shouldn't be at the beach either on the weekend. It has to qualify for times they're also not at work. It can't just be a work-related impairment. I just wanted to show this slide to tell you that the READS disability guideline, which you see on this slide, and I would write it down, or the ACOEM disability guideline, I would write it down, have guidelines of how much time people should be off for disability. So you don't have to guess at that information. Information is available to you. So I just wanted to point that out. Of course, if someone's confined to bed, hospital, and treatment program, have a contagious disease, that makes sense. Things like that will impact their ability to return to work. If they're harm to themselves or others, if they return to work, acute illness or injury that's exacerbated, exacerbating their chronic condition, those are things that would qualify, right? That makes sense. Simple questions to ask: is your patient being worked up for the condition? Meaning if they just have a condition and they're informing you of that and you're like just saying, yeah, I think you shouldn't go to work, you should be on disability or partial disability. Really? Has that person been worked up? Do you have confirmation that that's the case? And have they reached their maximum medical improvement? If not, what else can help them reach their maximal medical improvement? And is there objective evidence that supports the patient wanting to get back, or the possibility of secondary gain? So you have to think about that. Duration guidelines, again, look at the website that I provided, but you want to certify for more than 1 to 2 days per month. You need to know that if you're certifying for more than 1 to 2 days per month, you need to have in place certification for no more than 3 months, and then a 3-month review. And the time off needs to be paired with active treatment strategies. You can't just give them time off and nothing's happening in between. You need to try to promote active treatment strategies. You can't just say yes, and you can't give it for 6 months or 12 months and let it go on indefinitely. If they can't stand for more than 4 hours in a day, you need to reevaluate that in 3 months. And you need to base it on what you think. And if you need other doctors to provide input, like a physiatrist or neurologist or an orthopedic surgeon, they should be seeing those doctors to determine if that's accurate. So help your patient return to work. We mentioned that already. And I'll skip impairment or disability. And then the clinicians write activity recommendations. You just simply document what your patient can do safely and what your patient should refrain from doing. And again, think in terms of your patient's life, 24/7, not just when they're at work. And then if they're getting better, that should be noted on the next form that you fill out. And it should be based on sound medical judgment, not what the patient's telling you. And then again, employers make the accommodation. They will determine whether or not they can provide appropriate accommodations based on the medical information, even if all the medical information is accurate. Their business might not be able to tolerate having someone sit for half of their period of time. They may not be able to provide it. They do have an obligation to try. Okay, so clinician's role, employer's role, patient's role. The decision to provide and document safe activity levels based on sound clinical judgment is your responsibility and solely within your scope of practice, but the employers make the decision on whether or not suitable workplace accommodations are appropriate and are the employer's right and distinct responsibility to do. In the patient's role, they can decide to work or not work despite your recommendations, despite their symptoms. That's up to the patient. They can quit their job, lose their job, understand what's at risk. You can't control that. And I'll skip over, oh, here's a cute example. Someone, and I've had all of these examples happen to me. Patient will say, I can't work on Tuesdays and Fridays, or I can't work on Fridays, or I can't work on Mondays because of this reason, that reason, this reason, because I need 3 days off in a row and the weekends plus a Monday, or I can't work past 3 o'clock because of this reason. I have to go pick up my mother, I'm taking care of her, but are you taking care of any serious medical condition? You know, I have to wear sneakers because I have a bunion, even though there's a dress code. If you find that it just doesn't fit what, you know, what the patient's condition is, you have the right to just say no. So what's being asked on an FMLA form? Medical necessary time lost, follow the rules. Disability, follow the rules. ADA, be alert that the potential job loss, because if they can't make the accommodation, they can lose their job, but still only tell the truth, base it on clinical judgment. Okay. So the last thing I want to mention, and then I'll see if you have any questions, are we have something called the 4 habits of communication. Habit 1, 2 are about investing in the beginning when you first meet a patient, and then eliciting the patient's perspective. Habit 3 is about always demonstrating empathy when you're working with a patient, saying things like, I see that this bothers you. I can only imagine how frustrating this is. And habit 4 is investing in the end, making sure you have a plan and explaining your role as a clinician. If you haven't watched the 4 habit model communication that the MAVEN Project has available to help you talk with the patient in the exam room and develop sort of a structure around that, and believe me, it does help. You should watch that. But you can use that model when you're also telling patients that their illness does not qualify for FMLA, or if they're coming back with the FMLA form asking you to embellish it, that you cannot do that. You do not qualify to approve the FMLA. You only are qualified to provide medically sound information. You want to practice how to say that, how to do it in a genuine and empathetic manner. We don't have time to go in that today, but that will help you. You don't want to just say yes and provide information that's not accurate because you don't know how to say no. That's inappropriate. Okay, and sometimes you're writing to the patient in a text message or secure email or letter, depending on what's available to you. You still want to create a message that is empathetic and can state only imagine how frustrating this may be for you, and use some words that will tell them why you can't do what you can do. This is an example. Like, that being said, we should come up with a good treatment plan for you. I certainly agree with acupuncture and physical therapy. It may be worth having you see orthopedics or a back specialist as well. If you get a chance, schedule an appointment with me so we can discuss this. But it's not like, let me just fill out the paperwork knowing that it's inappropriate to get the person out of the room. Or you might say something like, FMLA requires an absence of at least 3 consecutive days, along with a provider visit for a serious chronic medical condition. It just sounds like the FMLA criteria might be stricter and with more current definitions, and you don't meet that criteria at this time. Sometimes they think they do because someone told them you qualify, but you should know whether or not that criteria is appropriate based on what's asked on the form. Okay, so in summary, FMLA provides employees with unpaid leave, usually a 12-week period of time and a rolling period of 12 months, a year, and a right to job restoration. People don't qualify often unless they've been on a job for a year and worked for at least 6 months in whatever year they are in. Leave can be for the employee's own serious health condition or a covered family member. Employers, not healthcare providers, determine employee eligibility for leave and whether sufficient information has been submitted to substantiate a serious health condition. Employees must present a complete and sufficient certification within 15 days of their initial request, and remember, only 7 days to get it completed again if information was missing. So please know there's a time clock going. Oftentimes, employers won't stick to that 15-day or that 7-day period, but they can if they wanted to. They have a right to do so. Healthcare providers must accurately certify the medical information requested on the form, and sometimes you may be unable to certify facts which support it, and that's okay. You can say no. Workers have the right to request work leave under ADA if they are substantially limited, and just know that the employers understand that right as well. And one of those work leave requests could be a work accommodation option, which would come to you to fill out. And there are some resources that you might find available that I included in the presentation. And I just want to say thank you for the time, and let me know right now if you have any questions for me.
Thank you, Dr. Leggett-Johnson. That was great. So again, if you have questions, you can type them in the Q&A box or the chat function, or just if you're unmuted, please ask your questions directly to Dr. Leggett-Johnson.
Quick question. I had an incident recently with a patient that had COVID and was taking time to recover. She didn't recover within 5 or 7 days. Everybody's recovering at a different pace. So is COVID being considered as one of the serious health conditions right now, or how is that playing out?
That's a good question. So there was a law put in place in 2020 that made COVID special when it came for time off from work. But that law expired in December, I think it was, of 2020. So that special time off that you could request for COVID no longer exists, and things went back to sort of normal. So it would fit the qualifications. Did the patient get hospitalized? Then of course that would help to qualify, because as you know, COVID could be more like a bad cold or flu, or it could be very, very serious. So it would depend on whether they met the other criteria. Hospitalization, or requiring so many days off, or requiring special treatment like seeing a pulmonologist and getting asthma treatment, because as you notice, asthma was on there. So I would say it depends.
A question. Thank you for the presentation. My question is about kind of the line between providing a work excuse and then, you know, when we enter into short-term disability and things like that. I've provided like work excuses to people that almost seem like, you know, they're long work excuses because the patient's in acute pain and they need to be evaluated by a specialist, but they're not giving me paperwork for ADA or FMLA or anything like that. So
Okay.
I guess I'm just wondering, like, the legality of my, you know, I have like a worry that my work excuse will be interrogated. And, I guess the question is, should I be asking the patients to bring me official paperwork, or should I just leave that in their hands?
No, I think you're fine. What you're talking about is a leave of absence, which I didn't address in this thing. Maybe I should have just mentioned that. A leave of absence is oftentimes required by many employers because someone will take a day off work. Let's say it's a Friday and you notice that this employee takes every Friday off, or 2 Fridays a month, or 1 Friday a month, every month for 6 months. And you're wondering as an employer whether or not it's appropriate. They may have policies that say for any 1 day or 2 days or 3 days, depending on your job. Our job used to be 3 days and we moved it to 2 days, that you are off for work, you need to provide a doctor's note. So what you're providing, it sounds like to me, is just a doctor's note confirming that the member was ill and needed a day off. And that's very appropriate. That's separate from FMLA, and that's separate from ADA or work accommodations. It's just an employee policy, and they put that in place to try to decrease the number of days people request off, even 1 day or 2 days.
Thank you.
Because every time,
Thank you. That makes a lot of sense.
Yeah, because every time you request a day off or 2 days off, you have to get a doctor's note. You will think twice about taking the time off, right? So that's what that's a deterrent.
I have a question just related to FMLA. When you don't have an official diagnosis, you have kind of a cluster of symptoms. They're requiring a lot of workup or a lot of time off, and they come in with the FMLA paperwork. So you don't really know what the official chronic condition is. How do you handle that?
If they meet the criteria. So for FMLA specifically, it stated on the form, was the patient hospitalized? If they required an overnight stay in the hospital, that almost automatically qualifies for some time off, right? Or if they are requiring to be off for 3 days because they're that sick, and then they're seeing specialists and they're getting a workup. Even if you don't have the official diagnosis, the fact that they can meet all of those criteria would still qualify them, and you feel good about it because you know there's something going on, even if you don't have the final diagnosis yet. I would say that's appropriate. I think that's one reason why the diagnosis is not required on an FMLA form, because we don't always have the diagnosis. But there has to be, when you look at the information, there has to be ongoing treatment plans. You have to see a doctor within a period of time from your symptoms, and you have to have follow-ups in a certain frequency in order to really qualify. If that's going on, then it's appropriate.
Thank you.
One more question. I know at some point we were talking about specifics, like as a clinician filling out paperwork, I don't know if it was a disability, how much a patient can lift, how much they can stand. In a situation like ours where we see other providers' patients, and maybe you only see this patient like once and they send you such paperwork and you really don't know the patient well, what do you do?
You want to give it to the PCP that's much more familiar with the patient. So that's one, as long as they've seen the patient. Remember, so let's think about this. If you're seeing the patient, but it's my regular patient, but this condition is new and different, and I've not seen the patient for this condition, then I won't have any more information than you have. If the person, broke a leg and you saw them and referred them to the orthopedic surgeon, I think you could fill out the form about how much the person can stand and over what period of time and when do you think that could improve. Shouldn't have to go back to the PCP. But if it's a chronic patient of mine and it's a chronic condition and it's a flare-up and I know the condition a lot better, it may be appropriate to come back to me because I know the patient much better. So I would say I would individualize the situation between acute, and I have just as much information or more than the regular doctor, or chronic, the doctor really knows this patient. I think it would be appropriate to give it to him or her. But I would never fill out a form and not inform the PCP, the regular PCP, that it was done. I just make sure they're aware. I doubt if they would object.
Thank you.
Any other questions? Those are great questions, by the way.
I think we are all set.
All right, well, that was wonderful. Thank you, Dr. Leggett-Johnson, for presenting and answering all those questions. And thank you, El Rio, for hosting us.
Yeah, it was a pleasure. Thank you, and good luck to all of you.
Thank you.
Bye-bye.